We move on to the next case. I invite Dr. Anju Kuriakose, who is a medical retina and UVR specialist at Chaitanya Eye Hospital and Western Eye Hospital, for her presentation Beyond the Eye, Vision Blight and Mother's Plight.
Good afternoon, everyone. I am going to present a case of a 38-year-old female came with complaints of blurring of vision in her left eye for the past 2 weeks. She has no history of pain, redness, or photophobia, no history of trauma. She has a significant past history of similar episodes in the past 6 months. She was treated with topical and systemic steroids elsewhere, and she was treated in Ayurveda hospital for 1 episode in that. On further examination, she gives her history of 2 pregnancy losses prior to the development of this ocular symptom. One was first trimester and next was mid-trimester loss, for which she was evaluated from the obstetrician, for which APLA was negative. On examination, in her right eye it was 6.6, vision was 6.6, and left eye it was 6.60. Lids and adnexa was normal. Cornea shows diffuse KPs in the left eye. Anterior segment showed 2+ cells. And iris and lens pigments were noted in the anterior lens capsule. Right eye fundus was normal. Left eye fundus shows severe vitreous haze with yellowish white fluffy retinal lesion seen in the posterior pole along the inferior arcade. We started on topical steroids and topical antibiotics, and basic uveitic workup and torch panel was sent, in which basic uveitic workup was normal, and in torch panel toxo was positive. So she was started on triple therapy, but we lost follow-up of that patient. So my questions will be, because she was started on how will the oral steroids alter the clinical picture without systemic treatment? Because she was started previously on systemic steroids before coming to us.
Yes, steroid can alter clinical picture, but lucky that there was no actually flare up of inflammation in such cases. Like toxo and ARN, these are the cases like sometimes if you, without any antimicrobial treatment, if you start oral steroid, then it can flare up the inflammation. But toxo, sometimes I have seen that there can be reduction in the vitreous haze also, and the lesion may remain same.
But then she was inconsistent with her treatment, I think. Even with the after second visit, she lost follow-up with me also.
Yeah, correct.
So next question will be, given the patient's history of multiple miscarriages, should further vasculitic workup be considered, because only APLA was done from the obstetric side?
So this patient required detailed workup for the toxo, because toxo also known to cause abortion and miscarriages. So I think you are on the right track. Autoimmune disease like SLEN will be this rarely can present like this. Yeah, you can do one ANA or specific panel.
Was the torch panel necessary in this case, or would toxoserology alone has been enough?
I think toxoserology will.
Yeah, one doubt to Dr. Partho. What is your drug of choice, sir, in a patient with no sulfa allergy and toxo diagnosed? Drug of choice.
Bactrim DS I prefer, and I prefer clindamycin also. But while giving clindamycin, I always tell the patient about the side effects of the clindamycin. But I feel that. And second thing is that intravitreal clindamycin is very good choice for these patients where there is a macula encroaching or macular lesions of toxo. Only thing is that we have to remember that the half-life of the clindamycin is 5 to 6 days only. So if you are giving clindamycin, you have to give it every weekly. And before starting the treatment, you should tell the patient that I will give injection and every week you need 1 injection. There is no point giving 1 injection and waiting to see the response for 2 weeks or 3 weeks. That's not going to work.
And you add azithromycin along with, or?
Azithromycin I don't give.
Okay, thank you, Anju. Next I invite Dr.